episode 110, Vestibular Research in Dizziness Rehab. I'm your host, Dr. Justin Trosclair, and today we're Dr. Carlo Rinaudo Perspective. Join 2017 and 2018 Podcast Awards nominated hosts as we get a behind-the-curtain look at all types of doctors and guest specialties. Let's hear a doctor's perspective. Welcome back. I have a great guest today. He's from Australia, and he was a chiropractor for almost 20 years. Well, I guess he still is, but he has a fascinating story on how he got super excited about vestibular, vertigo, autonomic nervous system type of neurology. And so he actually decided to go and get his PhD, and he's almost finished, but not quite. And one of the things they're doing is the rehab portion of how to help with vertigo and PVV, those types of things. He also is a lecturer, and he's created his own programs, about a 60-hour 4-module called NeuroConnect, and he'll discuss that at the end of the episode. But we're going to go through questions you should be asking your patients, especially if they're like, you're adjusting their neck, their headaches aren't getting better, their neck still hurts, or like they just got this weird posture. You know, questions to ask, maybe something more than just the neck's out. And then he'll go through like, well, here's some of the exam things that you could do, and here's something that you can do about rehab. So he'll give a little bit away. But just really a fascinating story. To me, it's always nice to hear what's going on in chiropractic from a neurology standpoint with the adjustment, and being able to broaden your scope and learn something new that you might have interest in, or you might realize you don't have enough skills to be super effective. And now there is an option. So again, you know, role the chiropractor plays in dizziness and poor balance issues, which the aging population, that could be super important. Managing spinal musculoskeletal conditions, brain style, neurology style, and are spinal dysfunctions even a result of local or brain-based problems to begin with? Before we get into the interview, you probably remember I had a no acupuncture knee giveaway on top of the normal 4. That's gone, or probably is going to be gone if you check. Now it'll be vertigo. So just kind of plug a little bit of the no needle acupuncture stuff. Obviously, it will not take the place of what he's teaching, but if you want a free download, see what points to use for some vertigo relief, doctorsperspective.net/vertigo. All right. All the show notes can be found at doctorsperspective.net/110. Let's go hashtag behind the curtain. Live from China, in Sydney, Australia, today we have got a PhD candidate in vestibular rehabilitation at the Neuroscience Research in Australia. He owns his own site called Brain Hub. It's a podcast as well. He's fallen in love with vestibular ocular reflex in patients and dizziness with chiropractic. Yes, that's right. He's a chiropractor as well. And he's taken the Carrick Institute. He's a diplomate of that. So please welcome to the show, Carlo Rinaudo.
Hey, how are you, Justin?
Good. Dr. Carlo Rinaudo.
In Australia, we're a little less formal, so Carlo works well. There's no lab coats in our office, no doctors.
Even as a PhD?
We're pretty casual.
You don't have your monocle?
Well, yeah, it's you can get in trouble unless you qualify the term doctor in Australia. So unless you're a medical doctor, even a PhD is generally got to qualify themselves post-name to say that they're a doctor of chiropractic or a PhD or a doctor of philosophy. So in Australia, we tend to use just our names, although we do have the ability to, but it is fraught with a little bit of danger at times.
Oh, so like if you were to introduce yourself at a party, which would be how arrogant, Dr. Carlo, you'd have to be like, I'm Dr. Carlo, chiropractor. Like that's, otherwise you could potentially get in trouble.
Exactly. You would, anytime on your social media, in person or a letter, you would need to qualify the term doctor by writing thereafter, doctor of chiropractic or equivalent, because our regulation board will look upon that not very fondly because it could be misleading to the public. That would be their term. Sometimes people just don't bother at all.
I think one of the 2 states that I'm a chiropractor in officially, it was the same way. You had to put, in advertising, you had to put DC of some sort in the back. But that's neither here nor there. I was just giving you a hard time a little bit. That's fun.
No, it's all good.
Okay. So you've been a chiropractor for quite a while, and give us a little backstory about yourself, how you ended up switching gears. You know, once you're in practice, sometimes to go back to school is kind of crazy, and with a family and everything. And then how'd you pick vestibular stuff?
Well, I've been in practice now going on to 19 years. Actually, before I got into chiropractic, I did a medical research degree, really got into research and I really enjoyed it. But I looked around my peers and I realized it didn't quite offer the lifestyle that I was looking for. I'm not afraid of doing work, but at the same time, I want to be rewarded for it. I didn't quite see that in the research profession. So I got into medicine, actually. I was accepted into medicine, and before I started, I had headaches due to my studies, posture and all those sorts of things. And a friend of mine was working as a CA in a chiropractic office, and he said, look, why don't you go check out this guy? And this guy had been around for a while, very experienced. And I said, sure. And I was a bit, it's a bit out there. It's a bit wishy-washy. Give me the hard, good chiropractic, the medical stuff. But anyway, I went, and I've got to say I was blown away. He did AK work, and I was like, well, fancy stuff at the time. I knew nothing about it. But I tell you what, it worked beautifully. And I started looking a bit more into it. I started seeing other professionals, not as a patient, but just started seeing what they do, what sort of life they led. Did some observation work, and I made a switch. I changed into chiropractic, and I was still working as a research assistant during the day, and I was doing the catch-up chiropractic degree at night, which is the first 3 years condensed because I had already done a medical science degree. And then the final 2 years were full-time master's degree in Australia. We have it as a master's degree. Got into it and loved it and really haven't looked back since. And really it was 3 or 4 years as being a chiropractor when I realized I had a lot more questions. I love the neuro. Wasn't very much a program or assistance person. I had questions. Why did this happen? Why do we see this? And so I got into AK because in some ways that was my beginnings. And that also raised a lot of questions as well. And from that, I thought, well, how is it that this part is connected to this? Why is it that we can do this test and we, with the head turned this way or the eyes turned that way, and we see a certain response? And the reality is the commonality between that technique and many other techniques is neurology. It was, how is everything strung together? How is it that we respond to the environment? And really, it was at that point that I got into neurology. I undertook my first course starting in 2004, completed it within a two-year program, and then it's been a life-changing event from there. And I've since taught it. I've taken the course a number of times, and now do my own version of it at a different level that it was taught to back then. So I haven't looked back, and I've thoroughly enjoyed the ride since.
Would you say that learning more about the neurology would help the clinical practitioner really excel at what they're doing more? Is it really that necessary to go that deep?
No, well, that's a great point. The person that I am and the questions that I had, I wanted to go deep, and it is a very deep rabbit hole. And the truth be told is that it doesn't appeal to everyone, and it certainly doesn't appeal to a lot of chiropractors. And I think it puts people off learning neurology. And it need not to. So, having taught the program and similar programs, the first question I get is, do I really need to know all of this? And the reality is at the end of the program, it's like, well, you may take only 10% of that information and use it effectively in practice. So a lot of it it's stored, but it doesn't get used. And, over a period of time, you just lose it. So I'm a big advocate of having a feeder program or something that is appealing to far more people, is more broader, is certainly more clinical applicable. And then, at a small percentage of those people that do that will go, oh my God, this is the answer to everything I want to know. I'm now going to go down that rabbit hole. But at the same time, and that's fine, and it will do that. And that's what happened to myself. But it doesn't appeal to a lot of people. And unfortunately, many people will look at the neuro nerds and go, oh, they're at that level. They're too elitist. I don't want to know about them, and it's too difficult. But there's a lot of baby steps that they could take that they will thoroughly enjoy the neuro. They'll thoroughly enjoy the results that they get with their patients without having to invest, $20,000, $30,000 in a program, travel every second week, every month, and spend so many hours studying. I mean, that appealed to me, but it certainly doesn't appeal to a lot of people. So I think there's a condensed program version that is certainly appealing, and I think is something that should also pretty much should be part of the undergraduate curriculum to a level that I don't think is taught at the moment. I think we're taught a very basic neurology, pathology model, and I used to teach it at university, but it's frustrating because it's typically not what we see as practitioners, particularly chiropractors, in office. We don't see the hard lesions and the hard pathology. Typically, they have already come to us from a neurologist or have been to a neurologist with a diagnosis of these conditions. And then it's the shade of grey that we see in our office that, what can I do to make this patient function better? We know that the spinal work has huge bearing, but it really is, it's not enough, and we need to open up our scope to how to assess and manage these patients. And that's where I think as primary care practitioners, we should be able to have a bigger toolbox to be able to help more and more people. And that's what I'm passionate about at the moment.
Been interested in the neurology? You get out of school, you go through school, like you said, and you kind of like, I feel confident in this based on like what I actually will need. And if I catch something that's like, oh, that doesn't seem right, we send them off to the neurologist. And I've had some people like yourself who've taken the classes and they're like, dude, it is tough. They're like, it's tough. It's hard. And then my thought was, as chiropractors, we get these diplomates, but to the outside professions, they're like, I don't care. I don't know what that means. It's not a residency. It's not a fellowship. To them, it's just like, so what do you extra stuff? What do you still can't do anything, surgeries or anything with it. So part of me was always like, if I ever take a class, I'd want to like look at the course and be like, okay, what can I take that's practical that I can put into practice? Because getting all this knowledge isn't going to give me a leg up in any other profession, I don't think, except in chiropractic land. So I don't know if that's true or not, or if you found that. What do you think?
Yeah, I do get that. I'm fortunate with my studies that I'm around different professions, a lot of neurologists, ENT surgeons, and I attend their seminars and I often present at these seminars. But I tell you what, having the neuroanatomy and neurophysiology understanding and the depth of knowledge that we've obtained, it's great to be rubbing shoulders and to talking to these medical practitioners, and they're looking at you going, how is it that you know about this and about that? So it's cool. Now, does it translate to me to the average chiropractor to be a better practitioner in their office? It's questionable. I mean, it's cool, and I'll
confidence will be there.
Confidence is there. At the same time, we need to be. I think we also need to be cautious because whilst our depth of knowledge is there, we don't have the scope to diagnose and to manage a lot of these conditions. We're at least in Australia. So right. In Australia, the word functional neurology or chiropractic neurology or chiropractic neurological consultant. These are terms that our regulatory body will literally pour you over the coals and fine you, and you may lose your license within minutes.
Wow.
So we're very restricted here in Australia, and whether that's a good thing or a bad thing, I think there's scope of practice that we need to be concerned with. So our advertising, anything I say on my website, in my clinic website, if I say that I can help someone with condition A, B, or C, I need to have a list of references on there to say, this is the reason why I think I can help people. And
oh, really?
Yeah, we have to justify it because someone of the public, remember, our regulatory body is there not to protect us as practitioners. They're there to protect the patients from unscrupulous practitioners who claim things when they shouldn't. So that's their primary goal. And they'll go through our websites and highlight things to say, you cannot say this because you've not shown evidence to do so. So it's difficult, which again is somewhat, I'm not against it because it keeps things in checks and balance.
Well, there's a lot of kookies out there that'll do some. I'm pretty sure America was first and then Australia got chiropractic second. So they probably saw the kookiness that was going on. They're like, yeah, we're not going to have that if we're going to have you guys come here. It's not going to work. At all.
I think there's a lot of test cases that our regulation board says, you see what's happening in the States? We don't want anything like that. So, and look, again, it has its advantages, disadvantages, and I think all in all, I think it's for the best. It is a little bit stifling, our environment, but
Well, things like herniated discs, disc bulges, is there anything, audience, we will get into the neuroscience stuff, but are there certain conditions that are like, look, you're approved, you don't need research to back up headaches, low back pain, disc bulges? Absolutely. Is there anything that's just sort of like assumed? Wow. I need to check out some chiropractic websites in Australia because those things must be thick.
Well, the ones that aren't are getting letters from the regulation board saying that this is not approved.
Strike one, or you're done after one strike?
Strikes. You have a period to update, and it can be quite stressful for a lot of people. So it's
know your rules.
It is what it is. Yeah, exactly. You do need to play by the rules here in Australia.
Yep, that's fair. Okay, so this is interesting. When I was in school, AK was considered. You definitely would get laughed at our school. They're like, look, if you're gonna go AK, you probably shouldn't have came to this school. Mm-hmm. And then even with I think the activator protocol, I'm a big fan of instrument adjusting, and one of the drawbacks of that is doing a leg check. Oh, one leg looks shorter. Touch here, and one leg goes short, one leg goes even. And you'll have some people that's the craziest thing. It doesn't work. But then if you talk to people who've been done activator for a long time, they're like, well, it's pretty consistent, and we don't know how it's working, but we didn't know how chiropractic worked, 50 years ago really either. So does the neurology show that this stuff is kind of accurate with the AK and that type of stuff?
I think it's emerging. I think now I'm not technique specific, and I sort of pulled away from these groups. I'm not in the inner sanctum as much as I once was, but I know some of these protocols are starting to introduce the neurology behind SOT, the neurology behind AK, the neurology behind various techniques, because I guess, again, they feel that it's a common language and common framework that can give some substance as to what they do. I know that they're introducing the neurology component into some of these coursework. I don't know to what level. They may be cherry picking things to suit what they're doing, and that's fine to an extent. I don't think there's many studies that have shown the reasons why these techniques work. So, I think if we have someone from the outside of our profession looking in, and they were to look at the quality of evidence with these techniques, I think it might be a little hard to swallow for some people. And I guess I think chiropractic is very insular. I think we have our people at the foot of each of these technique food chains, and in some ways they don't get asked a lot of questions about why or what they do and show me the evidence. I think it's, well, this is what we've been doing for so many years, and this is it. And you know what? If you want to build credibility, particularly outside of our profession, that's not the right way to do it. And the way I look at it is, if I had my supervisor, my PhD supervisor, who, by the way, is a biomedical engineer, he's not a chiropractor. If I placed on his desk, I said, would you mind reading this and show me how valid and how well does this stack up? To me, that would be a great test. Because he would pick it apart as an engineer would. And he'd say, well, that's that. How does that, why do they infer this? How do they make this leap from one point to another? And to me, that's what our profession needs, is someone from outside going, let's see how robust this study is. Let's not pat each other on the back at conferences, at our own modality conference, and say, hey, we're doing fantastic. But the truth is that the research world will look upon that and go, well, no, that's not the case. So, which is in part the reason why I've taken a PhD project and in a school and in a university that has absolutely nothing to do with chiropractic. I'm in the faculty of engineering, in the Department of Biomedical Engineering, in a university that has nothing to do with chiropractic. It's a very big medical and engineering university, probably one of the top 2 or 3 universities in Australia. And I want to have my research stacked up against the best in the world. And if a chiropractor's name's attached to it, my hope is that people look at this and go, oh, wow, that's a chiropractor doing a pretty good work. And he's ticking all the right boxes. And then my goal is that we can then feed that back into chiropractic with a level of credibility that is typically not seen amongst our research. And, the research is generally limited the best of times, whilst I'm very happy to say that's now changing. But from an external point of view, I want to add a level of credibility that our profession desperately needs. So that's one of my goals.
So your PhD is going to be in vestibular stuff. So
Correct.
Balance, dizziness, gait. To me, that has wide implications for old people potentially falling. For people who have like Meniere's or benign positional something vertigo, PVD. Everybody gets it.
I got it.
I mean, that's what we see in the office. So are you looking at, I'm curious how you got into that of all the things that you could have gotten into.
Yeah, sure.
And then when you're doing your research, is it to show that chiropractic can get better, or are you trying to discover something new about the disease, or just try to map it out, or
sure,
what's going on there?
Well, I got into this. So part of the neuro world opens up the brain as a window of how the rest of the body is working. So we can start looking at eye movements. We can start looking at certain areas of the brain working and how they're connected to each other, and how that influences movement, spinal control, and what we see as practitioners all day. And the vestibular system is one system that I was fascinated about because evolutionary, it starts very young, it develops very young, it's involved with how kids develop. It has strong connections with our autonomic nervous system, strong connection with our balance system, with our cognitive system, with our body awareness system. And all these, again, have direct influence on how our spine functions. So I was really intrigued by the vestibular system. And over the years, I took some courses, I read up more about it, and I just started having better outcomes in my patients with these conditions. So I had an affinity for it. I developed an interest, and then I got in contact with my now PhD supervisor about 5 years ago, spent some time in his lab, and he was curious to know what the hell was a chiropractor doing in my office. And then we started talking, and I said, listen, you know what, I'm due for a change in my life. Are you open to have a chiropractor as part of your, as a PhD student? And he said, why not? And it got started from that perspective. And really my PhD is all about, we're doing a clinical trial on a new vestibular rehabilitation technique. So vestibular rehabilitation is a broad term that's given to exercises to help people overcome dizziness and improve their balance, very broadly. And these exercises are either gait exercises, are either balance exercises that most chiros would use at some stage in their practice or be familiar with.
Like an Epley's or like a proprioception ball or something?
It's more proprioception. So it's more that, standing on a Duradisc or using a ball or doing tandem exercises or, doing things that involve standing and balancing, whether it be sitting on a ball or standing on a disc. So
even eyes closed, one leg up.
Exactly. So they're the proprioceptive-based exercises. Then there's ocular motor exercises, so how our eyes move. So we may give, people with dizziness conditions will typically have abnormal eye movement. So we might give exercises that help retrain these eye movements. Now this gets more in the specialized field. So most chiros won't do this, and most chiros wouldn't do a vestibular-specific therapy, and that involves positioning the head or turning the head rapidly from side to side whilst they fixate on a point. Some chiros know the Epley's maneuver, and they may know some of those type of conditions, but it typically most chiros wouldn't know beyond that point.
Right.
So my study is not chiro specific; it's research specific. It's basic science specific, but it can be extrapolated and it can have interpretations within the chiro world very, very well. And that's my goal. My goal is to translate that information and to penetrate that research field so chiros can be better positioned to say, I am now more competent. I can competent to manage patients better, to see more patients within this field, and to open up a scope of practice that chiros typically don't get involved with. I deal with a lot of medical specialists that wouldn't, 99.9% of the time, consider a chiropractor as a referral source for their patient that present with these type of conditions. It's generally a PT, an audiologist, but seldomly a chiro. Unless a chiro has built up that relationship with a practitioner, we're just not trained in that field. So one of my goals in studying this vestibular rehab is to have the skills and I guess the competency to then train other chiros to say, hey, listen, this is perfectly within our domain to upskill competent and to manage more of these patients so we can be more relevant in healthcare within this cohort of patients, which typically at this stage we don't do very well.
So what we want is for you to do really good job getting these systems taken care of, finalizing your PhD, so then you can potentially create some kind of program so that as chiropractors, physical therapists, whoever, I'm assuming at that point, can take a course of some sort and say, hey, when you leave here 1 weekend, 2 weekends, whatever it is, you can say, this is probably what you learned in school. It works for some people, but now we know here are other bags that you can use, more tools to help these kind of patients. You could probably niche down in this now, potentially a little bit more, and then you can learn like the complementary fields.
Very much
improving. So. This is who you would go to. This is when you would use an audiologist versus an optometrist versus just, hey, you need to go to a neurologist and all work together.
Exactly. And I'm very clear when I teach these programs to chiropractors is that let's not lose what we know. Let's not lose our history. I'm still a very big advocate of spinal adjustments. I still use spinal adjustments when appropriate. I'm probably a bit more selective when I use it in my patients, but I still do, and I see phenomenal results that neuroscience and neurology hasn't provided at times. Whereas, at the same time, I know when there's limitations. I know when to dive into my toolbox and to use other therapies that have given me results that I've not been able to see with standard chiropractic care. So I'm not about saying this, put down your adjustments and do what I do. I think collectively they will add to it, and you'll find times when one works better than the other. You'll find times when they will both work really well together. And again, when we're in an era where chiropractic has an image issue, and we collectively should be looking at not only getting our patients better, but also doing our profession a better justice, then I think it's important that we upskill in what translating that into better patient outcomes, but at the same time not losing our identity. And I think that's important. People say, well, the neuro guys just go off on all these tangents and they forget about what we do as chiropractors. I definitely don't say that, and I definitely don't advocate that. But at the same time, when someone comes in with a head tilt and you adjust their neck and you think that's the answer, but they keep coming in with, maybe it's because their vestibular system is not balanced, namely their otolithic organs, which are these little organs in the inner ear which help position our head relative to gravity. If they're imbalanced, one's not working well relative to the other, we're going to have a head tilt, or the patient will have a head tilt and present to you with sore neck with a head tilt. Now, unless you can identify that patient actually has a vestibular imbalance, not simply a neck subluxation or joint dysfunction, however you want to describe it, then we're doing ourselves, that patient, and our profession a big disservice. We can't identify where the primary problem is. And I think as chiropractors, we've always tried to position ourselves as looking for where the source of the problem is. And typically we look at the spine. And whilst that's true for a lot of conditions, it's not true for many others. And I think it's important that we broaden that look and look at other areas that could potentially contribute to why our patients present the way they do.
Diagnostically, let's go with the stuff we see in the office. Like you said, the head tilt, maybe they have nystagmus. They talk about being dizzy, so you do a couple different maneuvers, and you got the nystagmus. You're like, okay, that's a pretty clear case for maybe let's try the Epley's. But do you happen to have either one or two diagnosis nuggets for us to check out, like this probably is screaming more vestibular? And then do you have one or two therapies that we could possibly implement on Monday morning of just to complement what we're doing? So maybe like a take-home exercise, like you do Epley's, they're not going to be fixed yet. And they're like, well, can I do anything else at home? You're like, yes, you should try X, Y, and Z.
Sure.
Amazing results.
I think probably the best example to give would be someone comes in with a chronic neck problem. They've had it for years. They may have had it or months or years. They've been in your office. You've done your neck work. And whilst the joint mobility may improve, they're still complaining of a variety of symptoms. And it's important to listen to the patient. So the first thing I would say to the practitioner is ask questions. Because unless you ask questions, if the patient just, if you ask, you say a patient walks in the door and they're complaining of the same symptoms and you just get them to lay down on the table, you've missed an opportunity. So
it's not just tapping the atlas.
So I'd ask him, so I think one of the best examples to talk to chiropractors about as it relates to how to look at the brain and how to use brain-based therapies to help manage the neck or manage the spine is the whiplash patient. So, we've got many patients in our office that have had car accidents, sporting injuries, falls, blast injuries, fights, whatever it might be, that they've injured their neck. And if you ask a patient, either what other symptoms do you have, or if you lead them and say, do you get any blurred vision? Do you have any troubles reading? Do you get any lightheadedness or disorientation? What's your balance like? Any brain fog, poor sleeping, memory issues? Do you have any body awareness-based problems? You may think, well, what's this got to do with the neck? And any one of us that have been in practice for more than a week will know that someone comes in with chronic neck issues will typically have a lot of these symptoms. So the first thing I'd say to people is ask your patients, do you have any of these related symptoms? And more often than not, they'll say, yeah, I have troubles reading, or my balance is off, or I'm bumping into things, or I get lightheaded. I get a little bit of anxiety or fear when I move around. For the practitioner, you should be thinking, okay, it's now just not the neck, but now we're looking at part of the cerebellum. We're looking at part of your vestibular system. We're looking at ocular motor function. We're looking at higher cortical function. So how is it that the neck is related to these areas? And we know through particularly the whip neck to parts of the brain stem that have a lot of connections to these different areas is very, very strong. When we have a proprioceptive deficit, joint dysfunction in the neck, it will cause a change in signaling or brain coding to this, let's call it the black box within our brainstem. And this change in our black box will then have strong influences on our eye movements, on our vestibular function, on our balance function, on our higher cortical function, on our autonomic function. So if we have a problem with our neck, we're more than likely going to see comorbidities or concurrent symptoms or signs in these other areas. So it's important we ask these questions. So once we've established that, it seems like you've got some of these other issues going on, the next thing we need to do is, how do we examine these people? And again, it's not just put the patient down on the table, examine the neck, and that's it. We now need to look at and evaluate these areas well. So we may do a balance test. We may get a mats or a foam block and ask the patient to stand on a mat or a foam block and see what the balance is like. We may get them to walk along a corridor and see how stable they are. We may simply place our finger in front of the patient and just ask them to follow our finger from side to side. We may check their blood pressure and heart rate. We may get them to do some cerebellar tests, which you may remember from your undergraduate training. We may do some vestibular tests, and we may do the Dix-Hallpike, because with whiplash injuries, there is a force that gets displaced through the head and also the inner ear that may dislodge some of these little otoconia or crystals in the ear and contribute to BPPV or benign paroxysmal positional vertigo. So these are all the tools that you now have to go, oh, let me evaluate this so I can better understand what you're presenting with. So we may do our balance test, eye test, our autonomic test. We may do our cerebellar test. We may do our BPPV test. And once we've evaluated all these things, we can then say, okay, you're coming in with neck pain, but your eye movements aren't great. Your balance isn't good. Your body awareness isn't good. You've got BPPV because the whiplash dislodged those little otoconia, and now you've got the free-floating form, and you've got dizziness when you turn over in bed. Yeah, that's all right, I have that as well. So once we've got that, we can say, all right, I'm now going to put together a therapeutic plan, an exercise plan, a rehab plan in conjunction with your spinal adjustment to add to that. So we may do our Dix-Hallpike maneuver. We may do our eye movement therapies. We may give people a bunch of proprioceptive balance exercises. We may give them some targeting exercises that will help the cerebellum. We may give them some breathing or exercises or mindfulness exercises to help with their autonomic stresses that they're experiencing. So what I try to teach in my program is there's no cookbook approach. There's no step 1, 2, and 3. We try to teach a principles-based way of looking at the body. So once you understand how one area of the body is connected to another, it then opens up your understanding to, well, maybe I should look at this, or maybe I should look at this. Here's how I assess it. And based upon those assessment results, I'm now going to convert that into a therapeutic plan, into a management plan. And now this is what your home exercises or in-office therapy plan is going to start looking like. And it gets funky. It gets weird. In our office, we have people doing all sorts of things that are very specific to their history, examination results, and what their goals are. And once you can tailor something specific to the patient results are just through the roof. And we see some great results based upon the specificity of what we see. So it's hard to say, here's your 1 or 2 things that you would do. I would try to get the practitioner to ask the questions first. Based upon those questions, that's what examination perform. Eyes, balance, inner ear, autonomic, cerebellum, and so on. And then what you find in those examination findings should be turned around and become a therapeutic or a rehab exercise that you can do as an adjunct to your chiro very, very nicely. So I think in a long way, Justin, I've opened up Pandora's box because there's seldomly a one size fits all, but really what I try to do is get people to think about the first principles and use those first principles to be a better practitioner.
And I think that's important. I think that's what that's probably what some of the practitioners are going to want is, all right, A plus B. That's all I wanted. I just want to know what to do with it now that I see it. But in reality, one, it's not the way it's going to work because every patient is going to be different. But if you have a set of, I don't know how many different exercises, let's just say there's 10, you could be able to pick these 4 is what you would use for, they can figure out for this type of condition. You would use these 3 for this one. But then that's pretty much what you're trying to figure out right now for your PhD.
That's correct.
Yes. These are working.
Said.
These aren't. And then you're going to have control group and variation A, variation B, and just kind of seeing, all right, who's actually getting the best results with these different techniques. And you're just not there yet, right? Okay. Now you've got a seminar coming up in Hong Kong, which is interesting, in my opinion. But the brainhubacademy.com.au. Give us a little bit about what you're teaching. Do you ever make it stateside, Europe? Is it just Australia, Euro-Asia, I think is what they call it?
Okay. Brain Hub Academia is, I guess, one of my hats that I wear. It's very much along the lines that I've been talking to you about. It's getting chiropractors and practitioners interested and not scared about neurology, and I really want to make it translatable or applicable to their practice. And I hear this over and over that they just want a condensed program that they can use without spending many years or many thousands of dollars, and that's what it's aimed to do. So I've been teaching in Australia for a number of years. I'm in Europe a fair bit, and I'm in Asia a fair bit. I haven't been to the States yet, and I've got a number of practitioners and colleagues who are calling me out, hoping to get me out there, and I hope to do that very soon. But neuroConnect is really my new baby. It's a 4-part, 60-hour course that is aimed at really bringing the chiropractor up to speed with managing a lot of the conditions that we see, but with evidence, with a clear understanding of how things work, a chiropractic model using any of our identity. So yeah, that's kicking off in Hong Kong as of March next year.
Wow. So what type of things can we learn there?
Module 1 is all about laying the foundation of what we're going to do. It really talks about, I mentioned before about the neck and the neurology behind neck dysfunction. We know a bad neck only has so many deleterious effects on other parts of the body. But how do we explain that? We've used a bit of an outdated model for a number of years now, and I think chiropractors need to move from that bone on nerve, that analogy of pressure on a hose, and it's causing problems in the brain. I think that doesn't stack up. The research has now shown that there's a lot more to it, and it fits what we do very nicely. But I think we just need to be upskilled and we need to be versed in how we describe that. So module 1 is all about talking about how can we use proper terminology, what is the neuroscience behind spinal dysfunction and subluxation, what effect does it have on the brain, what is it that we can do to the brain that can have an effect on the spine. So we look at it from different points of view, but we want to get people to understand the connection with the spine and the brain. The autonomic nervous system is a beautiful, as we've seen people that, we've adjusted in the past and they've been unwell, they've had headaches, they've been nauseous, they've been lightheaded for hours or days after the adjustment. And we often think, well, that's just the adjustment taking its effect. And, we've put it down to, well, your body is not used to it and we need time to adjust and so. But the reality is that what's probably happened is that we've exceeded that patient's specific metabolic capacity. We've stimulated the brain at a point where autonomically they've not been able to withstand that type of input. And that tells us something. It tells us that they're a bit more sensitive. It tells us that we need to be more cautious in our approach. It tells us that if they're sensitive to this, they may be more sensitive to light and noise and motion in daily life. So again, we teach our practitioners how to look at the autonomic nervous system. How is that important for us as chiropractors? And once we have that information, in module 2, we talk about the examination. We show how to perform an examination, how to perform a detailed neuro exam, how to interpret the results, how to do a quick screen if you want to do something in a nursing home, how to do a falls risk assessment. So we do both the condensed and the more detailed version. We want to show practitioners how to do a report of findings that's neuro-based, how to do a review examination, again, that's neuro-based and based upon their initial presentation, how to perform a history, what questions to ask. So module 2 is all about, I've got this knowledge, how do I be a better clinician in terms of assessing and
that's really important.
Words to what use. How do we describe this to patients? Are we talking about bone on nerve? Or are we talking about sensory motor mismatch? Are we talking about, the beautiful neurology that happens? And patients get this, but we just got to be updated. And it's not just patients, but it's our colleagues and also our scribe, what we do to a doctor, that they're not going to roll their eyes and go, oh, here we go again. I want the chiropractor to say, we're describing A, B, C, and D, and the doctor to go, yeah, you know what, that makes sense. I understand that. I understand what you're doing. That's awesome. And, obviously we need that. And we want chiros to be a referral source. We want our game to be up a notch or two. And that's really the crux of what I'm trying to do.
And what's nice is it's not some sales pitchy weird, this is how you communicate for sales. You're like, no, this is what we're going to do. We're going to learn all about this neurology and then we're going to use it in layman's terms so that they understand what's going on. Because that was kind of what I was alluding to earlier is you got all this information and you're going to try to talk to some patient and they're like, yeah, you lost me at neuro practically. So just do what you need to do, doc. There's too much information. So that's great that you're trying to bring it down a little.
And I'll definitely, a lot of clinical pearls over 19 years of practice, what I've learnt and what I've seen doesn't work. We learn from our mistakes as well, and I'll be happy to share those. Module 3 is all about the spine, how it's controlled, balance, and posture. So, the crux of what chiros do and why patients present to their office is all about the spine. So we look at scoliosis. I want to show chiros what is another way that we can look at assessing and managing patients with scoliosis. And most of us look at, spinal adjustments or maybe taping, maybe bracing, maybe mirror adjustments. But what we don't realize is those spinal muscles are controlled by descending influences of the brain, particularly the vestibular system. So we're going to explore how is it that we can assess and manage people with spinal conditions like poor posture, like scoliosis, like recurrent back problems, with more of a brain-based approach. And it's cool. It opens people's eyes up. And again, I'm not here to take away from what we currently use, but I want to add to that. And for those 20 or 30% of people that don't get better with what we do, this could be the answer to it. And module 4 is all about integrative approaches to pain conditions. As chiropractors, we see a lot of people with back pain and headaches, chronic pain, chronic regional pain syndromes, things that specific spinal adjustments don't often help. When it comes to chronic pain, we need to be familiar with that the problem is not local, it's brain-based. And all the research now is talking about this cortical reorganization, how the brain reorganizes itself over time based upon a chronic injury. And unless we address how the brain interacts, perceives, and functions, then we're not going to help our patients with chronic pain by doing spinal-related work only. So we look at the biopsychosocial model. We look at nutrition. We look at cool and funky ways to get the brain to work better, like mirror box therapy, like left-right integration exercises, like a whole bunch of different eye exercises and body awareness exercises that help the brain recalibrate itself to understand what the body is doing. And it doesn't happen by doing our typical spinal work. So we're going to dive into that. So, I mean, the more I talk about it, the more I think, geez, I've got a lot to cover in 60 hours.
Yeah,
but,
you do.
The trick is, and what I pride myself on is distilling that information. So the average chiropractor, when I say average, the chiropractor who's doing musculoskeletal work, spinal adjustments, and doing great work at what they do, what is it that they're looking for? What is it that I can more to see the result? And they upskill and they get themselves to a new level and get our profession to a new level. So that's my task with neuroConnect, which starts in Hong Kong next year. It's I'm looking forward to it because it's and the truth is, hopefully I'll take this program and I've earmarked it for Australia thereafter, to Europe and hopefully the States. And I think it's something that our profession needs.
Well, selfishly, I hope you record Hong Kong, and then you can just sell it to us online for those who are like, oh my gosh, it's going to be 2021 before he finally gets out here.
I do often record my seminars because I'm a strong believer that it's I want to spread this. I don't necessarily want it to be all mine, and it's not my information. I must state this up front that the research is not mine at the moment. Whilst I'm going to be adding to it, a lot of it's out there. I just pull it in, I distill it, and I use my almost 20 years of experience, and I try to think, okay, what is it that I'd like to know? Topics, these slides together, because I go, oh man, this is awesome. I wish I knew this. I wish it was told to me in this way over the years. So, I'm pretty sure it'll be recorded. I'm not sure if it's going to be recorded in Hong Kong, but it will be more than likely recorded at a later stage. So yeah, stay tuned for that.
Awesome. Well, hey, before we let you go, I always like to ask, you sound like a super busy guy, obviously, at this point. You have a spouse. How are you able to have this work-life balance, keeping your family happy? You got any secrets for us?
Secrets. I'll tell you what I do, whether it's a secret or not. I mean, it works, and it's been working for the last 3 years. I study full-time, so I'm a full-time PhD student. But I also, in practice, 15 hours a week. And I travel probably 4. So I'm off to China next for 6 days. I've got Europe in March. I've got Europe again and Asia again. So I travel a lot. I have a family of 2 young kids who are at school, a professional wife who works. What I try to do is whenever I travel, my family comes with me. So during the school holidays, I both teach and spend time with my family, and my kids and family love traveling. So I try to integrate as much as I do with them. They're invested in my success. I do it for my family. I do it for my profession. I do it for myself. And I think once you've got a clear, what I do in my profession is very much tied with my values as a person and with my family. So it seems to blend well. I think if it was disjointed, if my family wanted something different or I couldn't do what I wasn't able to provide for them with what I do, then it wouldn't last. So I just tie it together, and it works really well with us. I'm blessed that I've got a very supporting wife, kids that love what I do and obviously love traveling, and they know that what Daddy does enables him to travel, and they'll continue, and they come along and they love that. When we travel and they go to, so at the moment awesome. It's working. It's working really well.
Dad's working, Mom and the kids are going to explore the city. Remember that time you weren't there, Dad, but you was kind of there. We went and had dinner. This is great.
I get photos throughout the when I present, and they're in shops or they're on amusement parks or they're here or there or they're on the beach. So I get that, and you know what? I don't begrudge that at the moment. I love that they're doing that. And I look at the audience. When I'm on stage, I sort of reflect at times, and I think, wow, last year I was in Japan, talking to 40 or 50 chiropractors in Japan, and I just pinched myself before I got on stage, thinking, this is ridiculous. It's great. And it all started because I watched a food show, and they're talking about ramen noodles. And I love Japanese food. And it was, and I said to myself, I want to get the best ramen noodles in Japan. How is it that I can do that? Got in contact with a couple of colleagues in Japan, and I said, let's put a seminar on. And, and about 9 months later, I was kicking myself thinking, it all started with me watching a show about ramen noodles. And I thought, this is pretty cool.
So when we find out where you're going to be at, we know this guy has an ulterior motive.
It is. It's generally food, or it's family. It's food. It's catching up with colleagues. I do have a lot of colleagues around the world, and I love catching up with them. Food, colleagues, and where does my family want to go on their next vacation? So if they say to me, Dad, I want to go to Disneyland in LA, probably I'll be putting on a conference in LA shortly thereafter.
Yeah, you may want to go to the one in Florida, though. Just saying. I'm partial. That's a longer trip.
It is a longer trip from Australia.
Hey, you got any books or podcasts that you think we should check out before we let you go?
I started many years ago listening to Disney, who I'm sure you and many of your listeners would know. All about gratitude. It's all about values, and
who was it?
Dr. DeMartini, John DeMartini.
Oh, okay, yeah.
Connecting and just being congruent with your values, to me, is such an important thing, and because of that, I just feel that things are just flowing for me. So I would get on to a lot of DeMartini's work, John DeMartini's work. It can get quite deep, or it can be quite superficial, but it worked really well for me. So that'd be something that I'd be encouraging new grads or people who are stuck in a rut to explore.
Very good. Dr. Carlo Rinaudo, chiropractor, almost PhD. Thank you so much for being on the show. And for those who don't realize we record early, I want to wish you a belated Merry Christmas.
Fantastic. Thank you, Justin. I appreciate your time, and I certainly hope your listeners got a lot out of it today. And as we bring in 2019, I hope they have a prosperous year and everything goes well.
Oh, where do people find you at? What's the website?
Brain Hub Academia. So BrainHub Academia, brainhubacademia.com.au. You can check out where some of our upcoming seminars are. They'll be updated very shortly, and I'm more than happy to take any emails or any questions that people have through carlo@brainhub.com.au.
Okay, guys, don't forget the AU.
Yes, that's right. That's .au, correct.
Well, that wraps up another episode. I want to remind everybody that we have some great affiliate links available. If you're into instrument-assisted soft tissue manipulation, we've got the Edge tool and we got the Hawk grips. Saves you about 10%. Also with the Edge, you've got the blood pressure cuff restriction system. You've got the G Suite inexpensive EMR in case you'd like doing cash practice. If you want to know what hosting I use for podcasting, it's Blueberry. Pure VPN, that's one of those ones I use to help keep my payments secure as well as access the internet more safely. You've got the Primal Paleo grass-fed protein, bone broth style. Save 10% on that. No sugar, allergy-free, gluten-free, dairy-free, all those types of things. Mentor box, get taught by the author. We got set for those floss bands that you may have heard about on one of the episodes. I really like those. Any Amazon products that you might want, click the link in the show notes pages. And of course, I got my own electric acupuncture pin to go with the no needle acupuncture book. From time to time, I'll have a bundle set where you can get them all together for a great price. I also have the free downloads at doctorsperspective.net/blueprints. And what lately I've been doing is substituting a fifth one. Like I've done a knee, and depending on the guest, I might do a different type. So check back there. So all those resources can be found at doctorsperspective.net/resources. There's also t-shirts at .net/t-shirts. Put up some new designs from time to time, like making lemons out of lemonade, shrimp po' boy, plus all the chiropractic and podcast swag that you could want. If you have any ideas for guests, please send me an email, justin@adoctorsperspective.net. I'd love to hear who you think would be good or a profession that you may not have heard yet. If you can, send me a review. That's .net/subscribe, Apple, Google, Stitcher, Android devices. You just click that button. It'll take you exactly to the page you need to. You can write a review, hopefully a 5-star review. Like I said, it does help for other people to discover what we're doing here. And we've got over 100 episodes. This is going to be like our 3rd year. Super excited. We're going to have a little mini-series like we've been doing, which has been fun. Hope you've enjoyed them as well. That's the feedback I've gotten. And one thing I haven't really talked about too much is the adoctorsperspective.net/support page. If you want to host a cup of coffee, go for it. If you want to pledge a little higher fee, there's buttons for that. There's even monthly recurring for those who feel like, wow, this is like the cheapest mentor coach program I've ever seen because you interview so many different kinds of doctors and I've been able to implement things that I've heard and it works. So monthly recurring payments, which also can get you my books for free, t-shirts for free, the first book, that deals with health and exercise, getting on a diet, getting your financial health in order as well, things I've learned in China. That book is available as well. And one thing that I don't have like a full-blown page about coaching and things, but there's a little button there. I've had people request, hey, doctors and non-doctors asking me, can I do more than just answer a couple of questions? Or could you be my coach for a little while? And I say, yeah, we can do that. So it's something I haven't really advertised, but it's something that I can do, whether it's marketing, some strategies for new patients, growth, those types of topics. If you're interested, just email me, justin@adoctorsperspective.net. As always, listen, critically think, and implement. Have a great week. We just went #behind the curtain. I hope you will listen and integrate what some of these guests have said. By all means, please share across your social media, write a review, and if you go to the show notes page, you can find all the references for today's guest. You've been listening to Dr. Justin Trosclair, giving you a doctor's perspective.